Good evening, everyone. Thanks, Shiv Shankar, for giving me this opportunity to speak on this particular topic. I hope my slides are visible and I am audible.
Yes, sir, you are visible and you are audible too, sir. Thank you.
See. So I'll be speaking very fast on the role of atezolizumab in treatment for first-line non-small cell lung cancer. Already, Shiv Shankar has texted me that I should be short and crisp. So this is my disclaimer slides that the slide set has been provided to me by Roche India. So these are the subheadings under which I'll be speaking over in next 15 minutes. So we all are aware that lung cancer is most commonly diagnosed malignancy among males if it has to be considered as a single organ after head and neck. And among lung cancers, 80 to 85% of the lung cancers are accounted by non-small cell lung cancer, and out of them, 90% are caused because of the smoking. Non-small cell lung cancer, they are slow-growing tumor with a variable initial overall response rate. Though the median age as per the literature is 70 years, but at least in our country, we have seen at least the median age of at least 2 decades earlier than what has been written in literature. Around 2/3 of the patients present with the advanced disease. So there's always unmet need for the advanced therapies for these patients. This is the evolving landscape of the lung cancer treatment. Before 2000, the gold standard of the treatment was only chemotherapy, though the advent which has occurred is chemotherapy plus anti-angiogenics based on histopathological subtype, which has marginally improved the survival. But after 2000, understanding the molecular pathways which drive malignancy, it has led to the development of certain targeted therapy which have significantly improved the survival outcomes in patients with targetable driver mutations. After 2015, there had come the immunotherapy, which has again has proven to be a boom for patients without any such targetable driver mutations. So there's always unmet need in the treatment of patients of non-small cell cancer, which have no actionable biomarker or targetable driver mutation, and that accounts for a substantial amount of patients. So these are the 3 studies, out of which 2 I'll be taking in detail. That IMPAR 130, which has addressed IMPAR 110, which has addressed atezo in PD-L1 selected patients, and IMPAR 150, which has addressed atezo plus chemo plus bev in non-small cell lung cancer. So this is IMPAR 110, where patients with advanced non-small cell lung cancer, chemotherapy naive, PD-L1 selected, and no driver mutation were randomized to either atezo or chemotherapy based on the histopathological subtype, followed by maintenance depending upon the response. If patient has stable disease or responding disease, they were either given atezo as maintenance in the atezo arm or chemotherapy based on histopathology in the chemo arm. The primary endpoint was overall survival. So this is the prevalence of PD-L1 expression, which were comparable in both the chemo as well as the atezo arm. And the other baseline characteristics also were comparable in both arm A and arm B. Arm B was immuno arm and arm B was chemo arm. So this trial actually met its primary endpoint because you can see the Kaplan-Meier survival curves separating patient with high PD-L1, that is PD-L1 stained tumor cells more than or equal to 50%, or tumor infiltrating immune cells stained by PD-L1 more than or equal to 10%. There was a landmark 6-month OS and 12-month OS of around 76.3 and 64.9%. with a hazard ratio of 0.59%, and the median OS was 20.2 months as compared to median OS of 13.1 months in chemo arm. Now you can see the overall survival in this forest plot in various subgroups. You can see all the subgroups actually are receiving the benefit except for one odd. And now coming to the progression-free survival. So there was a clinically meaningful improvement in progression-free survival. Again, you are seeing that at around 5 months, the survival curves are separating, and the median PFS in the atezo arm was 8.1 months compared to 5 months in chemo arm, and again with the hazard ratio of 0.63 and a significant p-value. Coming to the overall response rate, you can very well see with this bar diagram that overall response rate in atezo arm was significantly higher as compared to that of chemo arm, 38.3% vis-a-vis 28.6%. Now, safety profile is also very much important in patients with advanced disease because the quality of life is a paramount factor in selection of any treatment therapy or any treatment guideline for our patients with advanced disease. So you can see the adverse events, whether they are grade 3 or 4 or grade 5, the adverse event with atezo, that is immuno arm, was significantly lower in atezo arm, that is arm A, as compared to the chemo arm. Though yes, there were immune-related adverse events because of immunotherapy, but none of those individual immune-related adverse events crossed 10% mark. And immune-mediated adverse event requiring corticosteroid use was around only 10%. Now you can see the all-cause adverse events. You can see that majority of the adverse events are caused by chemo arm, whether it is gastrointestinal or hematological. Only few things which were significantly higher in atezo arm was transaminitis and hypothyroidism owing to its immunotherapy nature. So IMPAR 110 was a positive study which has demonstrated statistically significant and clinically meaningful improvement in overall survival, progression-free survival, overall response rate, and duration of response as compared to chemotherapy in high PD-L1 expression, which was defined by either PD-L1 stained tumor cell more than or equal to 50%, or immune cells infiltrating tumor cells stained by PD-L1 more than or equal to 10%. The safety profile was acceptable as compared to seen in other arms. There was no new safety or unexpected safety signal noted, and atezolizumab has very significant or favorable safety profile as compared to chemotherapy. Patient treated with atezo had a longer treatment exposure than patient treated with chemotherapy. The second trial, which I'll be telling in detail, is IMPAR 150, which has addressed the role of atezo, that is immunotherapy and chemotherapy, and anti-angiogenic, that is bevacizumab, in patient with only non-squamous non-small cell lung cancer. Here, patient with stage 4 non-small cell lung cancer who were chemotherapy naive and non-squamous were randomized either to atezo chemo or atezo chemo bev or chemo plus bev. There was patient with PD-L1 unselected, but yes, among the stratification factor, PD-L1 expression was one of the factors. And depending upon the response, whether stable disease or responding disease, patients were given maintenance. And the primary endpoint and the secondary endpoints are very much clearly mentioned in this. So why this triplet, immuno plus chemo plus bevacizumab, was selected? We know that chemotherapy-induced immunogenic cell death results in the release of tumor antigen that should actually enhance the activity of immune system, but because of a high expression of PD-L1 by tumor cells, that results in the PD1 and PD-L1 interaction and downregulation of T cells. So that interaction between PD-L1 and PD1 is being inhibited by atezolizumab, which is anti-PD-L1 monoclonal antibody, which inhibits the interaction between PD-L1 and PD1. And otherwise, bevacizumab normalizes the tumor vasculature, resulting in more and more T cell infiltration, and also it inhibits the suppression of dendritic cell maturation, enabling the efficient priming and activation of T cells. So, at one place there's release of tumor antigen, and other place the interaction between PD1 and PD-L1 is inhibited, so that the downregulation of T cell is also inhibited, and also normalizing the tumor vasculature results in more and more T cell infiltration. So baseline characteristics were well balanced. You can see there were around 15% of patients who had liver metastasis at baseline. That was also being matched among all the arms. And also this was the only trial which has taken the driver mutation patients, and around 10% of patients were EGFR mutation, although they have actually received the targeted therapy prior to coming to this trial. So this actually met the primary endpoint, and there was significant overall survival benefit with the addition of atezo in arm B, that is atezo plus chemo plus bev. You can see the 12-month overall survival, 18-month overall survival, and 24-month overall survival is better than the arm C, bev plus chemo, with a hazard ratio of 0.80, with the curves separating at around 3 to 4 months and are persistently separating with a median survival of 19.5 months with 14.7 in chemo plus bev arm. So there was improvement in median OS of 4.5 months that should be clinically meaningful. Now, overall response rate and duration of response are improved in all the intent to treat population, although the maximal benefit was achieved by a PD-L1 high patient. But you can see that even in intent to treat population, PD-L1 low and PD-L1 negative, also patients had improved response rate with atezo, chemo, and bev arm. OS benefit was observed across all the PD-L1. As I have said, that PD-L1 was one of the stratification factors. You can see in PD-L1 high, PD-L1 low, and PD-L1 negative, although the maximal benefit was achieved by PD-L1 high patient, but all the patients actually were benefited in OS, in intent to treat population. Now, efficacy in key subgroups. I'll take 2-3 more minutes. Now, EGFR positive after EGFR TK, as we know that we are aware that these patients with driver mutation do not respond well to chemo or immunotherapy. But in this patient who have received EGFR TK and has progressive disease, they were also included, and that accounted for around 10% of the patient. You can see that this particular combination where it has been shown that chemo plus immuno, these patients are not responding to, but chemo plus immuno plus bev, these patients are responding to. So you can see the Kaplan-Meier curves which are separating at around 6 months, and there's improvement. You can say the significant improvement in median overall median progression-free survival, that with a hazard ratio of 0.59. So one lesson learned, that whenever we are planning immunotherapy in patients with these targetable driver mutation, we should not give only chemo plus immuno. We should add bevacizumab wherever it is indicated. So OS benefit in patients with sensitizing EGFR mutation, you can very well see it was not seen in arm A or arm C. So neither in atezo plus chemo nor in chemo plus bev, this benefit was not seen, but in atezo plus chemo plus bev arm, it was seen. So overall response rate and duration of response was also improved with bev plus atezo plus chemo in the patient with EGFR positive non-small cell lung cancer. You can see that 71% versus 42% with a CR rate of 6%. That's again a good thing. And the median overall survival is almost triple of that of seen with bev plus chemotherapy. In liver metastasis also, there were around 15% of patients with liver metastasis, which is considered to be a poor prognostic factor in patients with advanced non-small cell lung cancer. Here you can see that landmark PFS was significantly better with a hazard ratio of 0.41. And the median progression-free survival is almost double with a very significant hazard ratio. And you can see that arm B versus C, there was significant separation of the Kaplan-Meier curve, but you are not able to see arm A and C separation of curves. So again, the lesson learned that atezo plus chemo plus bev working in patient with the liver metastasis upfront. So addition of bevacizumab again improved the overall response rate, as you can see this with this slide. Now efficacy in again third key subgroups. 2-3 more slides. Patient with bulky disease, with the disease burden more than or equal to third quartile, where low disease burden was defined as less than third quartile. So here you can see that the patients who have been given arm B, that is chemo plus immuno plus bev, there the median overall survival was significantly higher as compared to arm C, where the patient receives only bevacizumab and chemotherapy. These are the patients who actually require faster response, which require an efficacious therapy, providing the best outcome. So overall response rate is also significantly higher with this triplet rather than with the doublet of chemotherapy and bevacizumab, 62 versus 41%, with a hazard ratio of 0.70. So now it was coming to the safety profile. Again, the safety profile of atezolizumab was, and the individual drugs was similar to those of their known safety profile. There were no new safety signal noticed. Yes, in the B arm, where we have used 4 drugs, atezo plus bev plus 2 chemotherapeutic agents, there were higher proportion of treatment-related grade 3 to 5 adverse events. That is much obvious because of the additive effect of all these drugs. And immune-related adverse events were also seen in patients who received atezo, but all these adverse events that caused grade 3 to 4 adverse events and leading to the discontinuation therapy were not more than 5% in any individual adverse events. So IMPAR 150, this is my concluding slide, that again it is a positive study in first-line non-squamous non-small cell lung cancer with statistically significant and clinically meaningful improvement in both co-primary endpoint, overall survival and progression-free survival for the triplet, that is atezo plus bev plus chemo arm as compared to bev plus chemo arm. And also we have seen that in patient with the upfront liver metastasis and patient with driver mutations, EGFR, who have received the tyrosine kinase inhibitor and progressed, their addition of just chemo plus immuno or immuno plus or chemo plus bevacizumab has not resulted in significant benefit, but addition of or the combination of atezo plus chemo plus bev has resulted in significant improvement as compared to the other two arms. Atezo in combination with chemotherapy plus bev is well tolerated and its safety profile is consistent with its known safety nature without any new safety signal noticed. And also additional patient characteristics beyond PD-L1 expression should be considered. Maybe further trials will make us more intelligent to select the best therapy for our patient. This I have again. So this is in intent to treat population. You can see that 19.8 months, whereas versus 14.9 in BEV plus chemo, and in EGFR mutation, it is 29.4 months versus 18.1 months, and with liver metastasis, it is 13.3 months with 19.4 months. And also there was highest overall response rate with atezo plus BEV plus chemo as compared to BEV plus chemo. So I guess I ended up in time. Thank you. Thanks, Roshe, and thanks, Shiv Shankar, for giving me this opportunity.
Thank you, Dubey sir, for that excellent, lucid, and crisp presentation on role of atezolizumab, particularly in combination with chemotherapy and bevacizumab in the management of metastatic non-small cell lung cancer. And also, you have very nicely brought about certain subsets, particularly EGFR mutated lung cancer. And also, we all know that in immunotherapy, particularly those who have a liver metastasis, they do bad with immunotherapy. But you have clearly brought about that. However, with atezolizumab and bevacizumab, the scenario is different. Thank you again, sir.